talk about diabetes today. Let's go ahead and get started. So, pathophysiology, goals, pharmacotherapies, and games. So, what different types of diabetes do you have? You have type 1, type 2, and gestational diabetes. So type 1 is also known as insulin-dependent diabetes or juvenile onset diabetes. That's because it usually occurs in the early stages of life. So your B cells produce insulin in the pancreas. What happens with that type of diabetes is that your B cells are going to get destroyed. So the lack of insulin causes fat as an alternate use of energy in comparison to glucose. And this can lead to ketoacidosis, aka DKA, and symptoms associated with this, such as polyuria, blurred vision. So there is a test you can use called C-peptide test that could measure your insulin production. And the way you can measure to see if someone has diabetes type 1 is to check the glucose level, baseline. Then you have our type 2 diabetes that accounts for 90 to 95% of all diabetes mellitus cases, and it's associated with obesity, family history, and other comorbidities. And what's happening in that case is that there's decreased sensitivity to insulin, and unlike type 1, it is gradual, so your B cells actually become progressively damaged. So the difference between type 1 and type 2 would be, in type 1, usually the patient is normal weight or underweight, and type 2, you're going to have obese patient. And there's an A1C test that can be used to diagnose a patient as type 2 diabetes mellitus in comparison to regular blood glucose testing. And A1C of 6.5 or higher indicates diabetes. Then we have our gestational diabetes, which occurs during pregnancy. This can be temporary, although it can lead to further complications such as type 2 diabetes mellitus and obesity. There's also a test we can use called OGTT, or oral glucose tolerance test, and this can be happening during weeks 24 to 28 of pregnancy. So some symptoms of diabetes, and whether they are associated with hypo or hyperglycemia. Dizziness is mostly associated with hypoglycemia. Feeling thirsty is hyperglycemia, hungry is hypo, urination is hyper, and you can have either weight gain or loss. And these are some further complications. The most things to watch out for is just your polydipsia, polyuria, but one NAPLEX question that might pop up is your brown patches on the back of the neck, and that could be a huge indication for type 2 diabetes mellitus. So I'm going to hand it off to Sharon.
Hi everybody.
Press the button. Just move it. Yeah, move around.
Well, hi everybody. So here we have a chart with various blood sugar levels that a patient can have. And the times that we check a person's blood sugar is either before they eat or 2 hours after. And so if we check it before, that's their fasting blood glucose value, or it's also known as their preprandial value. And if it's checked after, it's referred to as postprandial. So here are the values. If a patient's blood sugar levels range between 70 to 100 fasting, that is considered normal. Now, if after that 2 hours that they start eating, it is less than 140, that's also normal. But if that fasting range goes above to 101 to 126, then they're likely pre-diabetic. And if after they eat it's between 140 to 200, then that's also indicative of they're possibly pre-diabetic. And then their fasting value, if it goes above 126, then they're most likely to have diabetes. And if it's postprandial more than 200, then they also are most likely to have diabetes. And that 200 value is also the value that doctors refer to in patients who go in for their oral glucose tolerance test when they're pregnant. Because if it's above 200, then they are likely to have gestational diabetes. So here are the treatment goals. The main goal that we want to look at is their A1C value. So we want their A1C to be below 7%. Then the other values that I have here is their preprandial. We want it to be between 80 to 130. Their postprandial, we want it to be less than 180. Then we also have blood pressure values for the patients, and that ranges based on their ASCVD risk. For example, a patient with high ASCVD risk is someone who had a heart attack, or if they have familial hypercholesterolemia. Like, these patients have a high ASCVD risk, and their blood pressure goal is less than 130/80. Now, if they don't have a high ASCVD risk, it doesn't have to be as low, so their goal can be 140 to over 90. Their cholesterol goals. LDL, we want it to be less than 100. Their HDL, we want it to be over 35. And their triglycerides, less than 150.
Okay, these are the guidelines, ADA and AACE. So I'm going to talk about oral hypoglycemic medications. Let's start with metformin. So metformin is bi-benign class and brand name is Glucophage, Glomexar, Neomed. It doesn't cause hypoglycemia and it causes modest amount of weight loss. Mechanism of action is decrease the GI absorption and gluconeogenesis, also increase insulin sensitivity, and one other action is inhibit mTOR pathway. So most adverse effects of metformin is GI, but it also causes vitamin B12 deficiency, and rare side effect is lactic acidosis. In lactic acidosis, everything is decreased. Decrease heart rate, decrease blood pressure, decrease temperature, and decrease pH. So indications for metformin is prevention and treatment of type 2 diabetes mellitus, polycystic ovary syndrome, management of lymphoma, because it's inhibit mTOR pathway, that way it causes autophagia, like a cell-plating of cells. Contraindicated in eGFR less than 30 ml per minute. Next class is SGLT2 inhibitors. It includes empagliflozin, canagliflozin, dapagliflozin, and orforgliflozin. It does not cause hypoglycemia, but it causes weight loss. So it is beneficial for overweight and obese patients. And a mechanism of action is block sodium glucose transporter. That way it excrete glucose and decrease the reabsorption of glucose. That way, it adverse effect include genitourinary infections, also hypertensions like volume depletions and risk of bone fractures. An indication is type 2 diabetes mellitus with specifically ACVD risk with and heart failure patient. Next is GLP agonist, is a semaglutide, is the only one. Rybelsus is oral medication. It doesn't cause hypoglycemia and it causes weight loss. So a mechanism of action is increased beta cell sensitivity to circulating glucose. It means it's a glucose dependent insulin secretion. General side effects is GI side effects, and indication is treatment of type 2 diabetes mellitus, and black box warning is thyroid CTL tumor. This class medication does not require renal dose adjustment. DPP-4 inhibitor that includes linagliptin, sitagliptin, saxagliptin, and alogliptin. This class also causes no hypoglycemia and weight loss, and inhibit the DPP enzyme. That enzyme is responsible for degrading the incretin. So basically GLP agonist and DPP-4 inhibitors, the mechanism is kind of same. So we cannot recommend patients both of medications because it's considered like kind of monotherapy. General side effects is nasopharyngitis, pancreatitis, headache, arthralgia, and myalgia. Next class is alpha-glucosidase inhibitor. It has acarbose miglitol, and that mechanism of action is decrease glucose absorption by inhibiting the alpha-glucosidase enzyme. General side effects flatulence, diarrhea, rash. But one thing is that is elevated LFT, so it's really important to monitor LFT while patient is on this class medication. And this medication is renal dose adjustment required because it's excreted renally. Next, sulfonylurea is also called secretagogues. It includes glimepiride, glipizides, glipuride. So glipuride is micronized and not micronized. So its difference is onset of action and half-life. This class medications cause hypoglycemia and weight gain. But why it's really important? Because it's drop A1C 1.5 to 2%. It's kind of similar to insulin. Mechanism of action is block ATP sensitive potassium channel. That way it increases the calcium influx and that causes exocytosis of insulin containing granules and release the insulin. Adverse effects include GI adverse effects, dermatology, hematology, photosensitivity, disulfide reactions with alcohol, hepatic side effects, CNS side effects include dizziness, drowsiness, somnolence and insomnia, both it can cause, and tremor. Increase the risk of hypoglycemia specific when patients taking this class medication, sulfonylurea plus alcohol, sulfonylurea plus insulin, sulfonylurea plus other hypoglycemic drugs, and specifically elderly patients, glipuride is in Beer's criteria. Glipuride cause more hypoglycemia compared to glimepiride. In long-term exercise and patients take low-calorie diet. Next is thiazolidinedione. It includes pioglitazone and rosiglitazone. These class medications do not cause hypoglycemia, but it causes weight gain. Mechanism of action, selective agonist for PPR alpha gamma receptor, and that way it increases the insulin sensitivity. Adverse effects include hepatotoxicity. So monitor LFT every 60 days for first year and keep an eye on the symptoms of hepatotoxicity. And this increases the risk of bladder cancer, specifically pioglitazone, Actos. And black box warning, congestive heart failure. So it's contraindicated, not recommended for patients who have congestive heart failure. And this medication also excreted renally, that's why renal dose adjustment also required. Last one is selective mineralocorticoid receptor antagonist. That is the new medication. Is FDA approved in July 2021. There is a finerenone. Is brand name Kerendia. Is available in the market. And this medication causes hyperkalemia. So it's really important to, prior to initiating therapy, verify serum potassium less or equal 5 milliequivalent per liter, and do not initiate therapy if serum potassium is greater than 5 milliequivalent per liter. And this one is helpful for patients with chronic kidney disease, with type 2 diabetes mellitus, and specifically patients who is not tolerated to SGLT2 inhibitor.
Thanks for attending. We appreciate you being here. I hope y'all are finding this informative and helpful on y'all's exam coming up on Monday. So I'll be covering the injectable options for the treatment of diabetes, and we have three categories in the injectable options. So we have amylin analog, and the first one we'll talk, or we won't even talk about it. We're just going to mention it as pramlintide, a Similan pen. We didn't really get tested on it, but the next two categories definitely pay attention. So we have GLP-1RAs, just like Asha mentioned, the PO versions, we have mostly injectables, and that's exenatide, lixisenatide, dulaglutide, liraglutide, semaglutide, y'all caught that, that's our GLP-1RAs. And then insulins, we got rapid, short, intermediate, long, and ultra long. For type 1 treatment therapies, the ADA guidelines suggest that all individuals most individuals with type 1 will be treated with multiple daily injections of prandial and basal insulin. So type 1 diabetics, you will see injectable insulin being treated. This is where you'll see your continuous insulin pumps, continuous monitoring, okay? And then so for our insulins categories, rapid acting, we have Lispro, Aspart, glulisine, and inhaled. The onset of our rapid acting, 5 to 15 minutes. Rapid acting, 5 to 15 minutes. Peak 1 to 2 hours, duration 3 to 5 hours. Short acting, we have regular insulin. I know it's cold in here, right? Yeah, we suffer. The short acting, regular insulin. Short acting, onset 30 to 60 minutes. Short acting, 30 to 60 minutes. Peak 2 to 4 hours, duration 6 to 8 hours. Our intermediate acting is NPH, and that's onset 1 to 2 hours. Intermediate, 1 to 2 hours. Peak 6 to 12 hours, duration 10 to 16 hours. And then we have long acting and ultra long acting, and that's Dedamir, Glargine, and Degludec. Onsets here will range between 3 to 1.5 hours. They have no peak because they're long acting, so they don't spike up. They just continue off and then they taper down, and these will last 6 to 24 hours. Here I've included brand generics. This is for your reference. We'll pass this, we'll share the slide deck for those of you who are interested. And then we have mixed insulin. So mixed, you have NPH, lipoprotein, and for these you'll see they have the mixture ratios in the brand names and the generic names. So just make sure you pay attention to the NPH, humulin, novulin. And then that last row there, the premixed insulins with your GLP-1Ras. We were tested on this, so I highly suggest knowing these. So degludec, liraglutide, Zoltofi, and glargine with sinatide, Sovigla. All right, GLP-1Ras. Here is our brand generic chart, and if it's long acting or short acting. And so you have your BID, weekly, QD. Pay attention to that. They will ask, I'm so sorry. And then some clinical pearls for GLP-1Ras. High potential for weight loss. So if you have a type 2 diabetic initially getting started, and they need weight loss, GLP-1Ras are a great option. And then also, these may cause GI upset due to the slow digesting time that they cause. And tell your patient to increase sugar-free, non-carbonated fluid intake, so water. I don't know if y'all know that translates to water. And that's to help to protect their kidneys. Also, they offer ASCVD benefit with semaglutide, liraglutide, and dulaglutide. So if you have a patient who comes in high CVD risk with weight loss and the newly diagnosed diabetic, GLP-1Ras are a great option. And then we do not want to use these meds in a patient with history of multiple endocrine neoplasia. And then we'll move into, here's our ADA guidelines, and you can see where we've highlighted the injectable recommendations. And if you notice here on the end, insulin, and here's the only place insulin is now mentioned. These are new guidelines in 2022. And so it's for patients who have cost considerations that need to be met. Other than that, you're gonna see up here at the top, you're gonna start off mostly with GLP-1Ras.
Here's a laser on it too.
Oh, no way, okay. And then here we go again, further with injectable therapy, if injectable therapy is absolutely needed. And then it just continues, I'm sure y'all have seen this. And now we have our insulin algorithm as presented by Ashil.
So then again, Faith also said that this will be available, so don't worry, we'll send this out. Make sure you fill out that form in the group meeting that we sent, or Faith sent. So next one is going to be going with Shil. Shil's going to we'll guide you through the different ways to titrate and also dose the insulins, okay? I know this is going to be heavy on PT, and don't miss out on that.
All right. So for the insulin algorithm, so GLP-1 receptor agonists are going to be preferred over insulin always, but not always, because the insulin might be your first drug of choice for a patient who have like A1C more than 10% or glucose more than 300 milligram per deciliter. In those patients, the insulin would be more preferred than GLP-1 receptor agonist. And if the patient is already on GLP-1 receptor agonist and the A1C is not on goal, then we can add the basal insulin or the bedtime NPH insulin, which can be started at a dose of 0.1 to 0.2 units per kilogram per day. And remember, this calculation has to be based on total body weight and not ideal or adjusted body weight. Or you can give the patient standard 10 units a day. So we are going to titrate this insulin, this basal insulin, until our goal is reached of 80 to 130, which is the fasting glucose range. And this range has to be met without achieving hypoglycemia, because hypoglycemia can be more deadly than hyperglycemia. So we can titrate the basal insulin dose by increasing every 2 units every 3 days. But we cannot just keep increasing dose, right? So once we reach the 0.5 units per kilogram dose, then we have to consider other options like adding prandial insulin. So prandial insulin is just mealtime insulin, which is given, suppose the example is insulin aspart, which is the Novolog. It is given 5 to 10 minutes prior to a meal. So once you see a meal coming at a restaurant, then you inject it. So this insulin is usually given, started with one dose, and it is given before a meal which contains the highest amount of carbohydrate, or which gives you the highest postprandial glucose level. That meal has to be selected for this prandial insulin. But if the glucose A1C is not met, then we can add the additional 2 or 3 prandial insulins to met the target goal. And if the A1C is still not met, then we can switch it to the full basal bolus regimen, which would be giving the prandial insulin plus prandial insulin is given 3 times a day plus 1 a day or 2 times a day of the basal insulin, which can be the long-acting or ultra-long-acting insulin. So here are some calculation. So we can go over this example. A patient weighing 220 pounds with A1C of 11.3% and fasting glucose of 258 milligram per deciliter. So since we can see the A1C is more than 10%, so the basal insulin would be preferred over GLP-1 receptor. So we can start the basal insulin at 10 to 20 units per day based on this calculation of total daily dose of 0.1 to 0.2 units per kilogram per day. But if the A1C is not met, then we can, as I said, we can increase the dose of this basal insulin by 2 units every 3 days until we reach the target goal of 80 to 130 milligram per deciliter. But if in other scenario, if the fasting glucose is in target below 130, but the postprandial glucose is out of range more than 180, then we can add the prandial insulin over here. We can start the prandial insulin at 10% of the basal insulin dose. So if the patient is injecting 30 units of the basal insulin, then we can initiate the 3 units of prandial insulin like insulin aspart given 5 to 10 minutes prior meal. And we can also titrate the dose of the prandial insulin by 1 to 2 units twice weekly until we reach the target goal of less than 180 milligram per deciliter. We have another case over here of type 1 diabetes. In this patient, the typical empiric dose or the total daily dose of this insulin would be 0.6 units per kilogram per day. And the target pre-prandial insulin is set by the physician. In this case, we give an example of 120 milligram per deciliter. So if the patient pre-prandial insulin is glucose level is high, then the patient would have to inject more insulin, in additional insulin to the regular one. So here's an example. So the correction dose can be found out by the correction factor. So how do you find the correction factor? You use the rule of 1800. So 1800 divided by total daily dose, then you get the correction factor. You plug in this correction factor into this formula, then you get this additional units. So you add the additional units plus the whatever the regular insulin dose was there. Suppose in this case 4 units before dinner, plus we get the correction dose of 2 units. So the patient is going to inject 6 units before the dinner to get the target goal. And insulin to carbohydrate ratio or rule of 500 is just nothing but the amount of carbohydrate which will be covered per 1 unit of insulin dose. So here are some insulin conversions which you will see in normal practice. You cannot just say like every insulin is same. So don't say that. If suppose we give an example of converting the NPH, which is the intermediate acting to long acting, or if we convert the long acting to ultra long acting, then we have to decrease the dose by 20%. And over here, another example would be conversion of insulin glargine to insulin detamine. A higher dose may be recommended if the insulin was dosed twice daily, or divided in twice daily. And here are some examples of GLP-1 receptor agonists, including Ozempic, which is a once weekly injection, and Victoza, which is the liraglutide, which is injected once daily. So we start with the Ozempic with 0.25 milligram once weekly for 4 weeks, and then we can switch it to 0.5 milligram once weekly for 4 weeks, and if additional glycemic control is needed, then we can switch it to 1 milligram. And same goes for the Victoza, we can switch it from 0.6 to 1.2 once daily, and if additional glycemic control is needed, then we can go to 1.8 milligram. All right, thank you. Now, game time.
Yay!
thank you for listening in, all right? So we're gonna go do the game, all right? So there's gonna be two different types of quizzes. This is using Nearpod as Delphin had to leave before.
Oh, so we're gonna do that?
Yeah, what we'll do is. So most of these, so the brand and generic game is going to be combinations. I'm not doing signal, brand and generics. Those are going to be the combinations. Is Dr. Mole is going to be very heavy on those combinations. Okay. And then the other one is we're going to do a adverse effect quiz. Okay, so I'm going to pull up the link right now. All right, give me one moment. Can everybody see the screen? I'm talking to more people on the very left side or very right side.
Yeah.
Can you see it? Now hand over to Rain and Obi.
Hello, guys. Everybody got it?
Not here.
What was that? Can you show one more time the code?
Looks like we have around
It's up there.
15 people, 20
Nine
people.
S
What was the
E
code?
three D up
It's
top.
there in the
Up top. No.
So around, when we get around like 15 people in here, we'll start the game, okay?
Hello, guys. We're starting. Should be able to see.
And this one is going to be, we'll just do it one question by a time, all right? So when everybody answers the first question, we'll talk about it and we'll review the answer, okay? And then what we'll do by whatever Rain and Obi would do. But first question, we'll answer all, and then she's going to review the answer.
Wait, do you have it?
No, it's just saying, it's not letting us answer.
How about now?
No. File for quiz.
The student.
Oh, we're on Zoom. Okay, there we go. Sorry.
Yeah, toggle.
Oh. Yeah. This is it. Okay. All right. We'll just let them answer the first one because we'll see it over there.
I was just.
10 minutes for 10 questions.
Okay.
Oh, okay.
So everybody should be wrapping up with the first question at the moment. So if you want to try to...
Let us keep going.
Yeah, you can keep going, but we're going to talk about every minute passes, we're going to do another question, all right?
So for the first questions, which of the following are adverse effects of Tragenta? So I've checked, somebody in your class sent me the notes, so I was able to see to make sure that Dr. Mo covered those two. So myalgia, inflammation, and pain. You also have nasopharyngitis. So for the hypertension and the hyperkalemia, the weight loss is another class. I think it's the SGLT2. Yes. So.
Everybody got the second one done?
Okay, so Rybelsus is an oral formulation of semaglutide and leads to 1.5% drop in A1C, and that's true. Number 3, which are the following are adverse effects of insulin? So we have diabetes ketoacidosis, we have hypoglycemia and A1C drop between 1 to 2%. You have lipodystrophy. Remember when you inject, when you keep injecting it, the tissue gets kind of like irritated, okay? So you have insulin allergies, insulin resistance, you have insulin edema, and also the weight gain. So, which of the following are side effect of sulfonylurea? So you have weight gain, that's really important. That one you must remember it. You have dermatitis, rash, eczema. You have hepatotoxicity, the bone marrow depression. You have the SI-ADH and the disulfiram reaction. We didn't, right? Number 4?
No? Okay.
I don't think we did. Yeah. So we skipped.
Okay.
Okay.
Everybody free answer.
So for number 4, SGLT2 leads to hypercholesterolemia, UTI, GI upset, and hypersensitivity reaction. That's false.
Because of the GI upset. It has nothing to do with the GI upset. So remember that.
The SGLT2. Yeah.
Remember it goes to the urine, that's the kidney, that's majorly where it works. So don't worry about the GI.
So it's gonna be hypoglycemia and UTI, reduced blood density and weight loss. It's not going to be hypokalemia and hypotension or hepatotoxicity and nephrotoxicity.
Excuse me? Yeah.
Yes,
Can I
it's
give you
hyperkalemia, yeah.
Okay.
The hypertension was right.
Yes.
Yeah, he's hyper.
Yes.
Both of them are hyper. You have hyperkalemia, hypertension. Hypotension,
Yeah.
hyperkalemia. So I did it on purpose because
This is Dr. Mo's question,
That's
how to
what we
ask. So just, you know hypertension, but hyperkalemia, so he's just going to treat like that.
And just treat it as when you think about hypoglycemia, you're urinating a lot more frequently. So the less fluid in your body, which means you have more of the electrolytes in your body, which means you're raising the concentration inside your body.
yeah. So remember that he always likes to put like two things like that will start the same. So hypo. Make sure if you see those hyper together, question yourself, is it that or not? if you see it, just remember to pause and read it. Because just think.
Which of the following will be incorrect as the side effect of diraglutide? And the answer is gonna be hyperglycemia. So number 8, which of the following side effects will not be experienced in a patient with metformin? Select all that apply. So the question is asking for which one is incorrect. So I know you might be tempted to put B as the answer, but instead of putting subnormal, I switch it with subsequent. And then for C, it has nothing to do with vitamin B6, it's B12. So.
You can go on to 9 and 10.
Yeah.
You can go to 9 and 10. We're almost out of time.
Linus is more potent, more lipophilic, and has a faster onset of action than manganese. That's false.
So remember, this belongs to the class of the sulfonylurea. So the glyburide, yes. So it has like two different,
Yeah.
right? So just remember that the microlase, that's the one that you want because it's more potent, and it's more lipophilic. So that's the better. So that's why it came last year, just to make sure that you have it.
And the last question is, let's all apply the following are autonomic symptoms of hypoglycemia. So we have anxiety, we have pins and needles, and hunger. Not depression or satiety.
Boy, depression is not.
Anxiety is not depression.
Any questions on this question?
How does society correspond with neurology?
Anxiety?
No,
Satiety. So basically, when you're hypoglycemic, your body is being deprived of what it is. So your body is sending out these hormones or these signals saying, "Oh, I need some food," but you're hypoglycemic. You're either delirious, you're not even in your right mind. For the hunger, that's about the same thing. But if you're fulfilled, you're not hungry, then which means you have the normal levels of hormones that is saying that, oh, I'm full.
Okay.
Right?
Boy, depression is not.
Depression, you said? So we're not talking about CNS depression or anything like that. This is more of an acute episode. When you're having a
hypoglycemic episode, you're either in a delirious state, you can't confuse, you might have anxiety because that's why you have that tremors with it, right? When you have tremors, usually associated with anxiety. But for depression is more of a long term over time. All right? Any questions on that? All right. But for the next one, we realized there was a flaw in our Nearpod. We're supposed to let you all do it first, and then we'll see the person who had the most right answers. But we'll do a raffle for anyone who came here, okay? So make sure you fill out the form, okay? We'll do a raffle for that first quiz. The second quiz, we'll let you do the whole 10 minutes, and then we'll see who got the full, what's it called? You don't have 10 minutes?
What for?
We'll send it after.
This is a group meeting.
Yeah, it'll be sent out in a group.
Yeah, no, you just started to be.
Entering another code or just starting again? It's starting again.
Oh, you want to share it in, just give it to me now. Okay. Oh, the demonics are a little bit over time, so. Yeah. Oh, your next class is at 1 o'clock, right? Yeah. Who's teaching?
To be honest.
Lab?
It's Yosemite.
Yosemite?
Oh.
Is she up there?
She never teaches that. It's Dr. Lavalley and Dr.
Okay, I'll go up there now. I'll explain the situation, okay? So make sure you just keep on doing it. I got it.
Yeah, you're good. Don't worry.
No, it's okay. You don't have to explain. They come late, like 20 minutes late.
I'll be up there to see if they're already there. Okay? All right.
Let's talk about it.
Right, yeah.
It's like,
Yeah.
provide
Yeah.
PTSD. Okay. So we know the machine. Are we going to?
When they're done. So.
When it's done.
Yeah. 13 questions.
Yeah, this
How did you find out?
He's in our group, so he texts me also in the morning. I'm so okay.
It kicked me out. Did they remove
Kicked you out?
Yeah.
I know it's happened like, you know,
Ooh.
stomach
Me.
pain or anything, so
Oh, what happened? Did you refresh?
I answered 6 questions, but it
You had a ruptured lung,
came
so you
out.
know the excruciating pain. My dad was ruptured too.
So did you go back in the Nearpod? It should make you the same.
I'm sorry. I knew I would be
And then
No, you're
the
not-
code
you're not his
is going to be 9 S
Right? Anything is
E 3 Z.
not a health professional under his care, nothing. This is only if you have a like a Britney Spears patient. Tell me anything. Like my sisters, my mom and dad, they're all going to New York and Washington. Doing what, you know, pictures and then you want to from looking at the green, looks like a lot of people got it right now. Doctor, hi, Dr. Oh, wait, wait.
Nice to meet you too.
Oh, so
Dr. Piper, what did you talk to? You can. What? Oh, so this is, we're doing an APHA topic discussion. Oh, right now? On diabetes.
Yeah.
We're finishing it right now.
We're finishing up.
Oh, okay.
What are you supposed to be the lab for the?
My name is on the schedule, that's why I'm here, yes.
I think they're upstairs.
The P2?
Yeah.
Y'all are upstairs, right?
Yes.
Yes.
P2 lab?
Yeah.
Yeah, so I am in the wrong classroom. Okay, thank you.
No, we're upstairs.
Yeah, we'll be upstairs.
We upstairs. But we don't have no case. That is why she canceled next week.
Hey, you know who mentioned? That was right there.
What's up?
We go have our dinner. I said my piece is already.
You guys are good.
I'm just waiting for 6 seconds so you can, I'll be going back.
Oh, hello. Okay.
This is ready?
Yeah, you should get it, you know, I'm studying.
No, no, we don't want to send the document.
Oh, okay.
For those who attend today, if you can give us like individual feedback, you can send it either to me. My name is Vincent Chan. If you haven't, known me, I mean, I hope. Or you can email or actually even message the group me to Faith Rutherford, our wonderful president of APHA.
Okay, Jennifer.
And then I will also include the emails and contact information for anyone in the e-board who participated today to give a presentation. So I expect there will be a lot of questions on the calculating for the insulin. So I will put this.
Came in and taught me yesterday.
Okay, well.
But we'll put the contact information. But if any feedback, what we can do better, what I see that we can do better is we send out the PowerPoints ahead of time so you guys can make notes. That was a slight oversight on my side. And also for the Nearpod, we'll use actually quizzes next time or Kahoot because we can't really do a draw for the first
The
time.
integrity is questioned on the Nearpod. Are y'all done? Did y'all finish the brain in there? Y'all good?
Yeah, you finish. You're good to go. We have the